All right, well, welcome everyone. Tonight, we're going to continue on with our collaborative care series. Um, Ankit Patel. You see Dr. Victor Davila is here as well. We're going to welcome back Dr. Brian Cohen, our orthopedic surgeon, and we're going to introduce Dr. Alberto Ardan, who's going to join us today as well. Today's webinar is going to be a focus on upper extremity regional anesthesia and thoracic surgeries and regional anesthesia considerations. As we talk with surgery anesthesia, as we have grown in the past few decades and a lot has changed. Tonight's webinar is also brought to us by one of our sponsors, PAJUNK. They are a needle company which I have known for over a decade. I'm sure Victor and Alberto, you've used some of their needles. It's really been revolutionary for me in terms of personal use, teaching, and colleagues in terms of the needle echogenicity. They do make a lot of other products, catheters, but we do appreciate their sponsor tonight and their innovations and technologies that continue to evolve. So with that, I will ask Alberto to introduce himself. Tell us a little about your practice and where you are today.
Yeah, thank you very much. So I'm Alberto Ardan. I'm an assistant professor at Mayo Clinic in Jacksonville, Florida. My current roles include I'm the director of our perioperative services area, so pre-op and PACU. I'm basically the regional anesthesia fellowship medical director. So I'm the fellowship director for that. And then also chair a couple of committees within the hospital. Outside of Mayo Clinic, one of my biggest roles right now is being president-elect of SAMBA, the Society for Ambulatory Anesthesia.
Awesome.
And very excited about that and being able to contribute to that society. I'm also involved in the American Society of Regional Anesthesia. So my interests really lie in orthopedic anesthesia, regional anesthesia, acute pain management, and dabble a little bit in chronic pain every now and then. But yeah, a lot of our practice is geared towards orthopedics, obviously as regional anesthesiologists, but we focus a lot recently on outpatient arthroplasties and and working towards keeping and maintaining our certificate of excellence in lower extremity arthroplasties. So a lot of same day discharge protocols. And then, not surprising, we also have a pretty heavy upper extremity practice too.
Yeah, amazing. That's awesome. So I think what we'll do is just like we do the lower extremity, what we'll probably just kind of go through with Dr. Cohen, maybe some of the surgery subtypes in the upper extremity, and then maybe kind of go between you and Victor and kind of go through some of the blocks that we would do for each of those surgery subtypes, and maybe which ones we wouldn't do based off the patient's health history and considerations for discharge and things like that. So before we get started, though, tell us a little about Samba's overall initiative. What are some of the things that some of our colleagues, surgical colleagues listening, would want to know about Samba, and maybe what their overall goals are and kind of what we can do to kind of help them?
Yeah, absolutely. So one of our primary goals as a society is to really further the ambulatory care of surgical patients, and working closely with other societies, such as the American Ambulatory Surgical Society, to really develop policies, procedures, guidelines that really facilitate a safe care of patients in an ambulatory setting. So it's not just ambulatory surgery. We also do, non-operating room anesthesia, office-based anesthesia, and we find that is a very big need that we have as we move away from having hospital-based procedures or outpatient centers that are associated with hospitals, moving away from those settings to pure standalone either offices or surgical centers. Then we find that there's a great need for that collaboration. In the next few years, we're also going to be focusing a lot on collaborating with other societies, both anesthesia and surgical, to really, things are much easier if we do a multifaceted and team-based approach rather for things. So those are our big focuses, as well as furthering research. We have a couple of funds set up to help further research in ambulatory surgical care, and working with other societies to do so.
That's awesome. Yeah, and Victor and I know this well, but this is kind of why we kind of streamlined this series. Really, is because we want to work in collaboration with surgeons, and the best way is just to kind of talk through some of our issues together. Like, helps us decide, why do I do what I do? Why does Dr. Cohen do what he does? So kind of learning that together, kind of breaks down into those barriers. So that's great. Victor, how do you want to get started? You want to go distal to proximal or proximal to distal in terms of surgery?
I don't have a huge. So let's start proximal to distal. Let's try that.
All right.
I think that or Alberto, do you have a preference?
Yeah, that sounds great.
Okay. Brian, do you want to go clavicle or shoulder?
I do mostly shoulder. I do a little bit around the elbow.
Okay.
But yeah, I mean, ideally, doing the regional anesthesia for shoulders is really, the goal for most patients, or for all patients. Where we have a little bit of lack of coverage is, if we do proximal biceps tenodesis with a rotator cuff repair. The shoulder is well maintained, but then the biceps is always something that wakes the patient up a little bit when we make that sub-pec approach.
Yep.
So I'm curious how you guys cover that area. Do you like the surgeons to use a little bit of local in that area with their interscalene block, or?
Yeah, so that's a good point, because frequently we'll tell the patients the following, that when they get an interscalene block, even if it's working perfectly, there are two zones really that a patient can still have some pain in it, right? And that's the axillary area, so that inferior area of the shoulder, and then the posterior area, right? So those are areas that, they do have some coverage, but like as you've alluded to, there's certain hot spots, so to speak, that are very common. So sometimes, we usually rely on our surgical colleagues to infiltrate that area, let's say in the axilla. But sometimes in certain patient populations, say somebody's like a high opioid chronic pain type of situation, in that one we'll probably try to do at least a separate subclavicular brachial plexus block, just to help cover that. Because that can be pretty painful. At our institution, we actually started doing a paravertebral block, a T2 paravertebral block, to help with that type of inferior pain. We find that is, while it's closer to the neuraxis, it does a good job of kind of filtering that pain out. One could argue that you could easily just do a simple, axillary block in that area, and that would work just fine. But it's such a simple block to do, all things considered, that we usually add that also, and it works pretty well.
So I'm gonna go backwards, maybe ask a couple of questions here. So you were talking about shoulder arthroscopy or rotator cuffs. We're not talking total reverse or total shoulder, correct?
Correct.
Okay. So for that particular surgery, Alberto, you're saying that you can do an interscalene and sometimes a paravertebral.
Yeah. So sometimes like the T1, T2 for that.
T2. Okay, so just to dumb it down, we're talking anatomically T1, T2. We're looking at which level of our scapula would that be? So if I'm looking to draw a line across T1, T2, you get your coverage to the dermatomal level of your inferior arm.
Yeah, mostly your inferior arm. Yep.
Okay. Now you chose paravertebral just from a skill set perspective. That's much more difficult. Have you guys
Correct.
ever done erectors?
We do. We every now and then. Now, as a I'll be honest, as a practice, we don't do erector spinaes as much, just because we're so facile at doing paravertebrals. But there are many situations where an erector spinae is perfectly applicable and gives not as much, but a similar amount of analgesia in that region.
That's great. Yeah.
Now, both of those, I would say, like probably are a little bit in your standard practice, probably not the first go-to choice that I would use. But that being said, if there's a major concern for that area, one could do a axillary block in that area, an infraclavicular or a supraclavicular block in a small dose to complement the interscaling, just to get those inferior fibers that cover that area.
Yeah. I'm interested about the erector or the paravertebral, just because I never thought of that really. And so in our practice, we do a lot of erectors because we have a large enough group where we have to sometimes teach and train. And so it's an easier block than the paravertebral block. And we utilize it a lot in actually cardiothoracic surgery. So our part of our ERAS protocol, our cardiac ERAS protocol, is we take the patient to the room, we do bilateral erectors before we put the patient to sleep. And so it's actually proven to be very beneficial for us. Our narcotic usage for the sternotomy has gone way down. Even for opioid use post-op, their wake-ups are better. So for cardiothoracic surgery, we've found a great utilization for erectors, and it's a pretty easy procedure, pretty easy block to do.
Yeah,
for thoracics, it's really useful because in thoracic surgery, you end up with like patients with pulmonary issues, and so they have to be able to breathe, and if they don't breathe deep, these are people that have like a high incidence of getting pneumonias and that kind of stuff, and they end up back on the vent. So like giving them that pain control is kind of critical. So erector spinae are, I'm much more familiar with them also as cardiothoracic procedures.
Yeah, and for us, we actually get a fair number of requests from our trauma surgeons, after rib fracture cases. So they're non-surgical patients that they're calling us to the floors and say, hey, what can you do to help this patient get off the vent? Because they're not able to tolerate coming off the vent, they're having a lot of pain. So we'll go to the floor and do a lot of erectors on those patients. And it's been working very well for us. So the single shots are great. I know there's some places that will put a catheter there too. Both are pretty easy to do, pretty low hanging fruit in terms of difficulty level for us. But that's been pretty good. Outside of those two, open hearts and thoracic, VATS or robotic thoracotomies, all those. Any other uses for the erectors that you thought of, Victor or Alberto? Have you seen?
No, those are the ones I've actually that's to kind of marry your point. I thought that was interesting about using it for that kind of proximal coverage. Alberto, what's your experience with some like local coverage? Like, have you ever played with like Extremity in that area or anything similar to that for those kind of like or Dr. Cohen? Like, have you ever played with that kind of stuff in those areas? Does it work? Does it not?
I mean, we'll inject some, we'll infiltrate some local in the area of the incision and stuff like that. We don't, Exparel is one of those drugs that are very regulated by the pharmacy at our institution. So I very rarely use it. Well, I don't use it personally, and the anesthesiology group very rarely use it because it's hard to get because of the cost.
Yeah, for us, I mean, I'll second that. For us, though, it's more of an issue of to be quite blunt, lack of data. We don't really have a good amount of convincing data that is in many ways significantly different than doing a single shot injection. Let's say if we're considering an interscalene block, right? One of the big concerns that we have is that if there is a single shot interscalene, that a patient will have rebound pain roughly about 12 to 16 hours after the injection, which can be very significant. And there's been a lot of data as to whether or not if a patient has a high amount of rebound pain, whether or not it was even worth it to do a single shot injection, right? And much rather do a catheter or do periarticular injection, let's say for doing a shoulder replacement. But nevertheless, I mean, one of our big things with that is that we haven't really found, and this was a few years ago, we didn't really find a big difference when using liposomal. And so we just kind of abandoned that. But we found kind of very similar results with lower extremity too. There wasn't a humongous difference. And it does limit the patient's care quite a bit. So as you all are well aware, there's a certain number of hours for which we can't do local anesthetic afterwards. That varies by institution, but at the very least, it should be around 72 hours, even though the FDA guideline is 96. But that definitely hinders us. Let's say if we get a consult on the acute pain service as to what to do afterwards, if a patient has received liposomal, what type of further interventions we could do as a regional anesthesia team. Depending on the region, sometimes we can do some additional coverage with plain bupivacaine that has, almost a negligible risk of bursting or causing an explosion of the capsules, the liposomes. But any other local anesthetic, it would be much higher risk and relatively contraindicated. So yeah, for that reason, we don't really pursue that as a venue.
Yeah. So you're much more, you favor catheters more if you wanted to place something, or do you just favor single shots in general?
Yeah, no. So we're pretty lucky. Let's say if we're talking about shoulders, that we do a lot of catheters. We have the resources to do a fairly robust acute pain service. and outpatient follow-up. So many of our shoulder procedures, including arthroplasties, are on outpatient basis. So we discharge the patients on the same day, with the assumption that they will have an interscalene catheter in place many times. I mean, of course, that varies by our surgical colleagues. Some prefer, for them just to do periarticular, some just a single shot plus periarticular, et cetera. But I'd say the majority of them, for significant shoulder surgery, do an interscalene catheter with an infusion at home for the next 48 to 72 hours, and that works really well.
Great. Yeah, so I think I guess that takes us to a certain point where the evolution of regional anesthesia has just changed every few years. When I first started, I think no one was doing any upper extremity blocks. Then we got to a point where we were doing catheters for a number of years, and then sometimes the catheters, how a mole becomes a mountain, so everyone's leaking, and then all of a sudden the patients were complaining about leaking, and so then it became, well, now we don't want to do a catheter, so let's just do a single shot, and we'll supplement them with some opioids, and it just changes every few years. So, I mean, Brian, what do you do in your office setting to kind of set the stage that the patients are going to have some sort of regional anesthesia, or how do you promote it?
I have a basic discussion with them that, the goal of the surgery is to limit, the amount of narcotics they have so that they have a low risk of nausea and vomiting, because that's a big concern of patients. Yeah. So, I preface that the block is one way for that narcotic load to be decreased, for the procedure. But I also educate them that this is, it's not a, and it's not a dimmer switch. This is a light switch. And although they'll say it may last 12 hours, it may last 6 hours, it may only last 3, it may last 24. You just don't, some people you just don't know. So it's just educating them on, start with your pain medication. And obviously we approach it multimodal. So they'll have an anti-inflammatory, they'll have a narcotic, they'll have a muscle relaxer, some gabapentin. So we'll have them kind of rotate these medications before they start to feel the pain, so that when they start to feel the pain, it's not as robust or rebound effect. Because I'll tell you right now, traditionally it happens at 3 o'clock in the morning, then I get a phone call.
Yeah.
So, yeah. But, curious to me was, early on, people were trying to do like shoulders, whether it's scopes or shoulder replacements under regional with, sedation. We don't really see that anymore. I don't know if you guys are seeing that where you are. That I don't know if it was more of just, well, if we could do it that way, it's safe for the patient not to be intubated. And some people use an LMA. I don't know what other people are doing around, but it was a big push, during my fellowship and stuff.
Yeah, it depends with positioning too, I think, right? Beach chair versus lateral. So some of the positioning helps dictate what we get to do, right?
Right. Yeah, and I would say traditionally shoulder replacements are done in the beach chair. I'm sure there are some out there doing it lateral or posterior.
Yeah, I'd say that, the question of whether or not to do purely a regional anesthetic with sedation versus regional plus a general anesthetic is I'd struggle to find any significant difference in patient outcomes when we completely avoid general anesthesia nowadays. And the big assumption is that using modern anesthetic techniques, right? So it was very different when the options were halothane and fluorine, right? And we're dealing with really high risks of nausea, vomiting, potentially other complications from exposure to those medications and older opioids, et cetera. So I think now today in modern practice, the potential advantages of just using a regional anesthetic technique with a small amount of sedation have kind of fallen by the wayside. I know that there are very specific centers that I think HSS is one of them that uses that still try to do that whenever they can, just relying on the regional anesthetic technique. But I'm not too sure that there are tangible improvements in outcome based on that. I mean, sure, the patient would probably get out of PACU a little bit faster, but in terms of things, that we could say like that really made a difference in the patient's physical therapy, et cetera. I'm not too aware of that data.
Yeah. And I think Victor and I might have talked about this one time in the past, but there is this notion through our surgical colleagues that a MAC is far safer than a general. And sometimes that's true. But you remember, when you have to do a MAC, you're sometimes giving 4, 6 of Versed, 50 or 100 of fentanyl, maybe a little ketamine in there, and that stuff lingers. Whereas just a little bit of gas, that comes off. That's
No,
gone.
I'd rather do a general than a Mac.
I agree.
Macs are harder because for surgeons, at least this is my impression, and Brian can correct me if I'm wrong, but my impression is that when surgeons want a Mac, what they really want is a general anesthetic with an unprotected airway. They want those patients really sleepy, and and so it's kind of it can be really people say, hey, the patient's moving. It's like, well, yeah, because it hurts, and so like if it doesn't hurt at all, then they won't move. But I can't make it not hurt and still have it be sedation. If it doesn't hurt anymore, it's a general anesthetic. So that's kind of where I land there. I kind of want to circle around really quickly though to that beach chair position, because I think there's some important points to mention there, especially, and this is actually a common point of contention between the anesthesiologist and the surgeon in terms of blood pressure control.
I will say one thing. I have never turned to the anesthesiologist and asked them what the blood pressure was, or asked them to lower the blood pressure, or because as a resident watching that bickering and it's something that I decided right away. And this is no lie, you could ask anybody. I've never turned to the anesthesiologist and asked them anything about the blood pressure in any surgery I'm doing.
I think part of that is it goes to probably your relationship with your anesthesia colleagues, right? So part of that is building that trust mutually and saying, okay, they're doing the best they need to for me, I'm doing the best I need to for them.
Well, at the end of the day, they're not looking over my shoulder and saying, hey, should you be doing that anchor with that repair? So why should I be looking over their shoulder and saying, hey, can you do something about, like a little bit more?
Right. As long as your screen's not completely red.
Well, present company excluded, just to kind of briefly touch the point for people that might have that tendency, that might be listening or might listen to this in the future. There is some really convincing data that decreasing cerebral perfusion for many different reasons, even transiently decreasing the amount of oxygen delivery can lead to significant cognitive changes for these patients. So as these patients get older, it has an increased risk of delirium. You have an increased risk of grandma has never been the same ever since she had her shoulder surgery. So this is not a benign thing to do. It's actually extraordinarily important to Alberto's point earlier, the modern anesthetic techniques. So it is important if there are any anesthesiologists listening to this, that we maintain slightly higher CO2 levels. That'll help keep that cerebral perfusion level where it needs to be, and make sure that we really, we don't want to do anything that impedes the surgery, but we certainly want to maintain at least what that patient is used to seeing, because, the pressure you are seeing, is not the pressure that their head is seeing, because that patient is sitting up. And and a lot of the things that we do during a general anesthetic impede that kind of auto regulation for cerebral perfusion. So, I thought I'd mention these things as long as we're talking about upper extremity surgery in that kind of beach chair position. I thought it'd be relevant to speak to some of these concerns, because these are not like, oh, well, sure, but as long as you don't have a stroke, it's okay. It's like, it turns out that is not true. They can have really, really significant, and that will impede their recovery and some of their ability to do physical therapy, et cetera. So it is an important thing to kind of factor in. And I just thought I'd drop that in, even though this is we're mostly focusing on regional techniques. I think it's really important to think about.
Well, no, it is, but I think to add to that, I think, the concern of that cerebral perfusion, do we as a society or as a specialty also want to think about maybe those are the patients we hold on the erector or neurontin? Like, Alberto, have you guys thought through those types? Like, at a certain age, what do you hold that? Because there's a little bit of fogginess afterwards. Do you guys have a cutoff?
Or in terms of age, or
like holding Lyrica or holding Neurontin?
Okay. Yeah. So that's a pretty hot button topic. So actually, for us, for any gabapentinoids, we actually stopped using them perioperatively a while ago. In our Rochester campus, there was a couple of large studies using our combined databases for Rochester, Arizona, and Florida that were done on several thousand patients that really suggested very strongly that patients who get any gabapentinoid perioperatively are at a higher risk of respiratory depression in the first few hours after surgery. Some of it is kind of minor, and some of it's pretty significant. I think there's another study about like what the cognitive changes were, which were also significant. So we, I'm not aware of any three of our campuses that are actually using gabapentinoids perioperatively anymore because of that. Now, sure, you'll have some patients that come in and their body's used to 900 of gabapentin every 8 hours. Fine, that's fine, right? Like if they took their morning dose, okay, not a problem, right? But to administer that as a multimodal protocol, yeah, we actually stopped doing that a few years ago because of that.
So
we moved away from it as well for that same reason. Something that to keep an eye out for is dexamethasone. It's coming down the pike, I think, as something that may replace that role.
So two-part question. So Victor, you're talking about your Decadron in the pre-op phase. You give it as soon as the surgery starts. Just give. I think there's, I've heard rumblings that there's some data coming that significantly higher doses than we typically give of dexamethasone for post-operative nausea and vomiting. We may be starting to give more of that, higher doses not to prevent more nausea and vomiting. That caps off at about 4. But to start having some of the other benefits, which have to do with the anti-inflammatory, the pain control benefits, etc. Those I would keep an eye out for data that may be coming down the pipe. I don't know about data, but I know we're at about 8 milligrams for now. I know some of our providers use
8 milligrams. Yes, but I mean, I've heard people mention doses as high as 20.
Jeez.
So we'll see how that data comes out after it's all said and done. But it's not here yet, but I'm just, this is something that's maybe coming down the pike,
The second part of that question, Alberto, is what is then the PO cocktail pre-op? What are you guys using?
Yeah, so our arthroplasty patients usually get 1,000 of Tylenol PO, 200 or 400 of Celebrex, usually 200, and 10 milligrams of Decadron.
Okay, so we've taken Lyrica and gabapentin completely off.
Yep. So no gabapentin or Lyrica preoperatively, and we find that's at least a good starting point for a patient's analgesia and to build on top of.
Great. All right. So let's move on. I think we've spent a good amount of time on the shoulder. Any other shoulder considerations that we've thought through? Obviously, the blocks. If we wanted to talk about the block, we're talking interscalene or supraclav. When do you decide one versus the other? Is it, for me, it's the COPD consideration possibly. If I don't want to knock out their phrenic nerve 100% versus 50% respectively. Any other considerations between the two?
Yeah, no, I mean, it's really like what their anticipated tolerance of a hemidiaphragm paresis is going to be. The thing to keep in mind too, that's very dose dependent also. So especially if you have a catheter to work with where you can, place it with a small amount of local anesthetic, check it with some saline, and then kind of slowly start ramping it up, like 5 cc's at a time until the patient has some analgesia or some numbness in the expected deficit area without any significant, problems with respiration. So it is a little bit of a trickier thing. The other option there is it's a superior trunk block, which is, again, it's dose dependent, but the superior trunk block is probably less likely to cause as much of a phrenic nerve paresis as the interscalene. It's not that dramatically much different in terms of location, right? It's just a little bit lower down with the ultrasound. But if you use a smaller dose, it does have the advantage of potentially less phrenic nerve involvement. So I kind of use those interchangeably, and it's kind of a little challenging when you're teaching the fellows too, where the probe usually slides down a little bit when they're trying to do the block. And I'm like, okay, well, you didn't exactly do an interscalene. You got a superior trunk, which is fine, right? It'll accomplish the same end, and sometimes to the patient's benefit too. So, but I think those are the 3 big ones. Yeah.
Okay, and then for our surgical colleagues listening, when you say smaller dose, you mean less potent. So, 1/4% versus 1/2%.
Oh no, so I mean, so usually it's our usual practice. You keep it's more volume. So 0.5% ropivacaine, and using 10 cc's instead of 15 or 20.
Okay. When would you ever consider the 0.5% versus 1/4%?
Oh, that would be, I think if I were considering that, I'd probably choose another block. So if I think that the patient would not be able to tolerate a safe amount of 0.5% ropivacaine, let's say. For
Mhm.
an interscalene block, I'd probably start choosing another block because the chance is always there that they could have the same effect even with 0.25% ropivacaine. And again, it's volume dependent too. So if they have enough volume, that could still happen.
Okay, fair enough. So moving on to possibly a different block and different surgical areas, the axillary block, and then maybe upper arm and elbow. What are your thoughts and concerns around which type of block to do and for which surgeries?
Yeah, so axillary block is a great, classical block for, mid arm, a little bit downwards. So I think that is a very useful block. It is relatively easy to do. Technically, it's not too difficult, right? With the use of an ultrasound, I would hardly find anybody who would be willing to do it any transarterial approach like we did 15 years ago, right? But
Right.
it is a very useful and quick onset block, right? And that's another advantage of it, where if we are considering using that for mid arm to and distal to that analgesia or anesthesia, it doesn't take too long to set up. One big caveat is that when we're doing the block, we have to make sure that we get the musculocutaneous nerve and not just infiltrate the median radial and ulnar nerve around the artery. So that is especially if there's a kind of like a bicep distribution where the surgical incision is going to be. So we have to be really careful if that's the case. But yeah, so the caveat is whether you do an axillary, an infraclavicular, or supraclavicular, it's going to accomplish the same things, right? Supraclavicular still has a little bit of a chance of causing phrenic nerve issues. So the safest bets, if those are a concern, would be to do an infraclavicular or an axillary block for those purposes.
I found that over the years, 15 years now, that the infraclavicular has become increasingly more difficult, positional wise. So, and the axillary being so easy that if you're comparing axillary versus infraclavicular, and you're adding a musculocutaneous coverage, that for our practices seem much easier, not just from a technical perspective, but teaching really, right? So teaching purposes, it's become easier.
Yeah, it's a great block. I mean, especially for people that are too short for their weight. Those the axilla tends to stay nice and lean. So it does a good job for that. I'm sorry, I didn't mean to interrupt you, Alberto.
Oh no, I was about to say something similar. Yeah, I mean, I think the technical difficulty with performing an infraclavicular block now is mostly related to body habitus, right? Nowadays. So the average patient's BMI has incrementally gone up, and it gets a little bit more difficult to visualize that adequately with an ultrasound beam that gets you a good 5-6 centimeter distance depth, but no more than that on a reliable basis. So I think that is one very big advantage of using an axillary.
Brian, what are your surgical practices for elbow, or do you stick in mostly?
The two things I do mostly around the elbow, some not fully elbow fracture work, distal humerus, but triceps repair and biceps repair.
Okay.
That's about the extent of it.
Okay. And are you prepping your patients similarly with any kind of conversations around promoting regional anesthesia, or the same as before, really?
It's the same conversation, the one thing about when you're doing a biceps and, they have, usually get it like they'll get some motor, obviously compromised. You obviously there's nerves involved and you're just like, okay, is this the block? Is this my surgical approach? And it's just that witching hour of, when it wears off and where are you and where am I?
Yeah. Now, trauma aside, are there any surgical procedures that you're concerned about, any, neurological motor function that you would want your anesthesia colleagues to know, hey, this is a case where I kind of want to test motors, so, or sensory, don't block them. Like, what are any kinds of concerns or considerations?
I mean, usually we're just doing distal biceps, we always worry about the posterior interosseous nerve, just being stretched. Usually it doesn't get cut or anything like that. So it's just, but I still do the blocks.
Okay. So you wouldn't have your colleagues or your anesthesia partners block those?
I would let them block them. It's interesting. This goes back about 20 years. One of my anesthesia colleagues tore his biceps and we he had a block, and he woke up obviously with, motor compromise, and it was just, and he had a long acting block because, they wanted to give him the best block ever. So it was like 24 to 36 hours of no motor function. And it's like, okay, well, so.
So he was sitting there freaking out until the block wore off.
Well, I was freaking out. I'm sure he was fine. Last thing you want to do is compromise your anesthesia colleagues surgically, and then have to see them every day. That's and talk about how they can't, do certain because of the procedure you did to them.
Yeah, right.
I'd like to set up Alberto with a question. I don't know if you want to just tee it up for him. So I think Ankit was just recently kind of alluding to the issue of trauma or potential, concern for compartment syndrome related to, blocks, and, whether that decreases the sensitivity of, finding those kind of compartment issues. Do you have any thoughts on that, Alberto?
Yeah, I mean, that there's such a mixed opinion on the use of regional anesthesia in high compartment syndrome situations. The classic example is that if somebody has, for lower extremity, having a tibial plateau fracture, right? And then that being a little bit higher risk, as I understand it, and just having like a little bit higher acute trauma situations where there's an increased risk of compartment syndrome, whether your regional anesthetic technique will mask those symptoms. That is a real concern. There has been some publications, mostly case reports or case series, that suggest that otherwise, that the presence of compartment syndrome pain is going to break through any local anesthetic that's in there, right? And that that will not prevent appropriate timely diagnosis. Usually, for our practice, I think if our surgical colleagues are worried about potential nerve injury from the procedure or any significant edema or swelling from the procedure, they'll tell us not to perform a regional anesthetic technique in that patient, and then they'll do a local anesthetic infiltration around that, and we'll manage the patient's pain otherwise, especially when we're dealing with the higher risk tumor, like malignancy resections, right? That's a fairly common request, especially when they're operating in a very, sometimes we'll get some massive brachial plexus associated tumors where there needs to be a timely, as soon as possible, post-operative assessment of their function, right? So that's where we'll hold off, and we won't do any regional technique.
So we've not done this before, but something that just came to my mind was, have we ever done any regional anesthetics after the surgeon has had a chance to do a motor function or a sensory function test?
Oh yeah,
I don't think I signed up, but you could, right? So is that part of your practice there too? Then once the surgeon is able to check.
It depends. It depends on the situation, but yeah, we've definitely had those before, where if a patient, let's say it's a lower extremity tumor, and they really want to check sciatic function before we do anything, right? And then afterwards, then we can perform a popliteal block. So that has been known to happen. Likewise, this is a little bit of an advantage of having a catheter in place too, where you could just place a catheter with saline, have it ready to go, right? And then as soon as that exam is done and the surgical team is satisfied, then you start dosing it up to get appropriate analgesia. So there's a couple of ways, but yeah, I think that it's that communication piece is very key, because absolutely, what we don't want to get in is this situation where we think we're doing the patient good by anesthetizing their extremity, and then turns out that we potentially have cause a little bit of an increased risk of inability to diagnose neuropathy. So
Brian, I was just thinking about that, but ulnar repositioning is a pretty common procedure we have scheduled for our surgeries and surgery centers where I worked before and where I am now. Is that a procedure where you'd be concerned about us doing a block because you're moving the ulnar nerve, or kind of?
I mean, I've done the procedure. I don't think I'd be concerned with the block, just because in that situation I'm knowingly moving it, so I feel like you're even more kind of careful with how you're doing your procedure, as opposed to if you're doing some type of humerus fracture and you don't really know where you know, the nerve is, and then you want to make sure that it's not getting trapped in the fracture and stuff like that. So, but for me, you know, whatever keeps the patient comfortable, and the anesthesiologist is comfortable doing that part of the regional anesthesia.
Right. Going further down from the elbow, obviously we're going down to the forearm, and the fractures, the same blocks, axillary with the muscocutaneous coverage should cover those. Actually, in that scenario, the axillary without needing to do that muscocutaneous coverage should be fine for anything elbow and below, correct?
Yeah, correct. Yeah.
And what are some of the most common things you guys are coming into for in terms of below the elbow? Wrist fractures, thumb arthroplasties, things like that?
Yeah, all of the above. Yeah, those are common ones. You know, we have a fairly robust plastic surgery service too. So they'll do let's say, you know, a subacute fracture, and they'll also be involved with repair of the soft tissue at the same time if there's like a more complex situation. And then we find that, you know, doing the regional anesthetic technique not only helps with the analgesia afterwards, but really, you know, promotes the healing process by, you know, vasodilatation and increased blood flow to that extremity. So that's another potential benefit that we have in these particular situations, usually for surgery below the level of the elbow. That really makes a difference in terms of patient healing.
Mm-hmm.
It's also really useful for AV fistulas. I found. I mean, when we would do them with basically minimal sedation, and regional when they were doing these kind of AV fistula creations, surgeries, or revisions.
Mm-hmm. Yeah, in fact, I think I had surgeons sometimes more often request a block for that reason than for the pain management reason. And so then we're able to do this successfully under MAC with less sedation, obviously. What about any pediatric considerations for upper extremity in terms of blocks, types of blocks, or do you ever add anything to any of your blocks? I'm adding several parts of this question, but pediatric considerations and maybe additives into any of your blocks in your practice?
Yeah, so I can't comment too much on pediatrics because we don't have a pediatric service in our hospital. But on the issue of additives, yeah, there's something to be said about whether or not the addition of, for example, dexamethasone does prolong the duration of the blockade enough to make a significant difference in the patient's care. So the typical thought has been, you know, that to add something like 4 milligrams of preservative-free dexamethasone to the injection, the local anesthetic solution, and that would probably increase the duration of the block by a couple of hours or so. Depends on the patient. That might be, you know, that might be great, and that might be, you know, not really worth the addition of it. One thing to remember is that anytime we add any substance to a local anesthetic solution for use perinaturally, right, there's a potential chance of having some sort of neurotoxic reaction. So we always have that in the back of our minds. So sometimes, you know, there'll be some injections that have local anesthetic and dexamethasone or Precedex, right, which can also increase the duration. But the kind of theoretical thought is that the more stuff you add around a nerve, the higher the chance theoretically that something might hinder that nerve's proper function after resolution of the block. And that's food for thought a lot, especially if we can get a similar effect by giving that medication intravenously, as is the case for dexamethasone, right? So if you did 4 of Decadron IV versus 4 of Decadron in the injection, and you get a similar amount of subjective analgesia from the patient, right? And that's that's a separate issue, but that does make you question as to whether or not it's worth it to do it.
Yeah, I've always been a fan of just keeping things super simple, and that's why I've actually never added anything to our blocks, Decadron, Precedex, Clonidine, any of those things, just because I felt like the local did a good enough job for so many years that I'm not going to try and mess with it. So that's always just been my practice. But Victor, how do you guys do things?
Same. I've always like every time I've looked at the data for these adjuvants, it's just I've never found that the juice is worth the squeeze. You know, it's just not like, you know, I've yet to see a convincing study that says that this is something that you should be doing for sure, and it just makes it messier to figure out what's going on.
Well, and that applies to other types of anesthetic techniques, maybe outside of this conversation. But you know, a lot of the IV lidocaine infusions, magnesium infusions, on top of Decadron, Precedex, ketamine infusions, all in the same patient, on top of also giving narcotics and a general anesthetic. I've always just been very weary of, some of the newer movements that have been trying to, some of those techniques, just trying to add too much to the sink, because it's just not so proven to me yet. But I'm not sure if you guys have seen different, and maybe I'm just behind.
No.
Yeah, well, certainly. Yeah, well,
no, go ahead.
One thing is certainly the question of what term that we heard in the last few years was opioid-free analgesia, right?
Yeah.
And so that's something to be very careful with, because opioids do have their risks, right, as any other medication does, but that doesn't mean that we should avoid them completely. And this is a very big issue that some folks have taken to heart as part of their practice, and I would caution that really needs sometimes a reevaluation, because as you mentioned, if we're avoiding opioids for the sake of avoiding opioids, and we instead use a multitude of other medications that have their own potential side effects, right? We could be setting up a patient for a really long PACU stay that was not really required. Side effects from any of those medications, right? God forbid we have some situation where, you have a ketamine, psychosis that happens in recovery, right? And so when we're trying to avoid opioid respiratory depression, we exchange that for another problem. Having some good amount of judgment as to what would be most beneficial for that patient in that particular procedure at that particular time. What we like to call opioid optimization, right? So you just give the patient what they need for that specific situation. It might be a little bit of fentanyl, 100 micrograms, and that's it. Or for another patient, it might be that plus 2 milligrams of Dilaudid,
Right.
And then with some regional anesthetic technique too. I mean, we do have those situations where patients, have a decent amount of analgesia from their regional anesthetic technique, and they still have some decent amount of pain too. And we just have to, we have to treat that.
I think that's always been the key. I think the key is always, there is a huge, the opioid epidemic was a huge trigger. Is a huge trigger for us to be very cautious about our narcotic usage. But to your point, what's probably more important is for us to focus on regional opportunities when it applies, and still using an optimal amount of narcotic when needed. One of the things that I found is, when we have providers that we either train, whether they're physicians or CRNAs, they often sometimes will say, well, I'm trying to not use fentanyl, so I'm going to use ketamine. And sure, they use a good amount of ketamine. They might get through PACU, but what they forget is that when they get through PACU, they've got to go to our outpatient area before they go home. And that falls on me or you, Alberto, or you, Victor, because we can't send them home because they're just gorked. And so while the provider who did the case says, oh yeah, look, this did very well. I didn't give them narcotics. I gave them 50 or 70 of ketamine, and they did great. It fuels their opinion on how well they did without giving narcotics, but they don't see the later stages of what Dr. Cohen, you even see, is that the nurses call us and say, hey, this guy's not ready to go home yet. He's still talking gibberish. And so those are those trickle-down effects that we sometimes have to tell our peers and colleagues and say, yeah, you got through PACU, but now they're stuck in phase 2.
I have two things to kind of stick on this. One, I forgot what the second one was, so I'll start with the first one. Is that with the opioid epidemic issues, I think it is important to mention something very quickly. Is that first of all, I'm never afraid to give patients that have issues with previous drug use, et cetera, or previous substance issues, giving them enough pain medication to cover their needs. Yes, the therapeutic window tends to be very narrow, but it doesn't narrow going down, it narrows going up. In other words, you have a certain amount that's going to cause that respiratory depression, and as those patients that that have a history of substance abuse, what ends up happening is that the upper limit tends to stay the same, maybe goes up a little, goes up, but then the rest of it shifts up to make it a very narrow therapeutic window, but they do require more pain control. And the second thing I want to mention about that population specifically is that often these patients are on buprenorphine or methadone, and they're instructed to stop those drugs to to allow them to kind of, get the benefit of some of the opiates they might get perioperatively. That is extraordinarily dangerous.
Yeah.
Please, you should never, ever, ever do that. They should continue those medications straight through the entire perioperative period. And that's really important. Mm-hmm. Even if they're going to get additional medications or other medications, they should be getting those. They should stay on their buprenorphine. They should not, and they should be given very specific instructions to continue it, because the mortality, the 30-day mortality after if they relapse, is just astronomical. So it's really important for that patient population. And because of their histories, they often visit us more frequently than the general patient population. These are patients that tend to be frequent users of our services. Mm-hmm. So I just wanted to kind of make that as a quick plug. I want to disseminate that as much as I possibly can. And the second thing is, I wanted to echo Alberto. I remember now. I wanted to echo Alberto's point related to opioid optimization. Yeah. Because every time we do a study related to some sort of adjuvant, we're saying like it decreased opioids by this much. It decreased opioids by this much. And so the tendency is, intellectually is like less opioids is better. Therefore, the best is zero opiates. Mm-hmm. And that is not the case. The best is the right amount of opiates for that particular patient. And so I think that, I wanted to echo that point about, even though all the studies seem to be set up to kind of imply that the best amount of opiates is to make it not zero. Obviously, that's always a nice outcome, but right. We should not, we should use them when appropriate, because they, you can't, they became really popular for pain control for a reason, and sometimes considering opiates like intrathecal morphine, other intrathecal opiates, other kinds of like modalities for administering them can also be considered, but at the end of the day, they are there for a reason. They are popular for a reason, and so we should remember that.
Well, I think it's a lot about patient education. So oftentimes, I'm sure many of us come across our patients who come to us and say, "Well, I don't want any narcotics because I don't want to get addicted." Well, that's not going to happen, right? When you have a surgical stimulation that requires some degree of comfort or pain relief, you aren't going to get addicted, and that is a common thing that I come across, where people are like, well, okay, I don't want to get addicted. And so it comes from, our responsibility is to educate patients that you're not going to be addicted from getting the appropriate amount of safe, narcotics in a controlled setting when it's required, and to your point about the buprenorphine, we have in our clinics, we've instructed everyone to stay on their medications. I'm a big fan, I'm sure that all of us are, on keeping patients normal. And so whatever keeps you normal, take them. Neuromeds, pain meds, psych meds, heartburn meds, all the things that keep you regular, stay on them, because you're going to be going home in about 6 hours.
Oh, right? Incidentally, pro tip for buprenorphine, if they are on Suboxone, there is IV buprenorphine, and you can actually use that as a pain medication during the perioperative setting, and it works like a dream. So that's something to to consider as well. Instead of hydromorphone or other kinds of agents, you can actually just bump up their the IV version of the buprenorphine, and that actually works quite well in my experience. They get a lot of the pain control without that respiratory depression.
Is that in formulary in a lot of places? Alberto, do you guys have that?
No, we do not.
Yeah, I'm not sure if we do either.
Yeah, we have it, and I use it basically if somebody's on Suboxone at home. My first line treatment is to treat them for their acute pain with additional doses of buprenorphine, and it works really well. I mean, some patients will rebel and say like, no, they're for reasons that I can only I don't want to attribute, but they don't want to try that, or they but I've had that happen. But I will say that when patients are open to using it and getting it, they tend to do really well with it. So it's something to consider if it's in your formulary, etc. Just something that I've noticed has worked well, anecdotally at least.
That's great.
Yeah. So one thing about one of the comments that you made, Victor, is about measuring opioids in a lot of the literature as an outcome, right? And that I think that speaks to a greater issue that there is within when we're looking at pain-related literature is that that's not a very good outcome measure as a metric. The use of opioids is not that great. Just like the pain score, right, is not that great. it's very subjective. You can look at it as kind of like an abstract type of thing, or like, okay, this intervention seems to have helped, but pain scores are going to differ a lot by population, by individuals, et cetera. And so the question is that what we're not looking at are really patient-centered outcomes, right? So things that make a difference for getting patients out the door, make a difference in their recovery for the next couple of days, not just while they're in recovery, right? Not just while the first night after surgery, and really how well they're mobilizing. You know, we had just recently done a big systematic review about this, about lower extremity arthroplasties, specifically for outpatient procedures, right? So outpatient arthroplasties, what does the data show in terms of using regional anesthesia techniques for these patients? Out of over 3,000 articles that we screened, we found 2 that were specific to outpatient arthroplasties. And of those 2, only 1 really talked about these patient-centered outcomes, right? I mean, that speaks volumes as to like where we are in terms of, you know, the use of, or rather us using usable data metrics, where we can say like, look, this technique really makes a difference in a patient's care, when you look at it from a macro level, right? So that's just kind of my own 2 cents on that we have to be really careful when we interpret outcomes in terms of pain scores or opioid outcomes, because they're just a small slice of the picture, and they don't really give you a good idea of what's going on from a bigger perspective.
But sometimes when they're sensationalized, that one study can really be like advertised so much that it becomes the standard of like, well, that's true. It was in that one article, and so you're right. That's dangerous, and I think we have to be very careful about all the things that we kind of read in here.
Yeah.
All right. Let's see. Well, we're getting close to our time. Are there any closing remarks, Brian, you might have for us in terms of thoughts about how upper extremity has kind of changed practice in the last couple of decades of your practice?
You know, really going back to the beginning, I really think it's important that, as surgeons, we can have an opinion about what we'd like, but at the end of the day, it's who's doing the procedure that really needs to make these decisions. And that's, the few people that end up staying overnight in the hospital are those that usually have phrenic nerve involvement, and they're compromised pulmonary wise. It's obviously one of the risks of the procedure, but at the same time, it's nice to have your patients not writhing in pain when you go to see them after their procedure. So I think there is a huge benefit to regional anesthesia, obviously, but I really think it's important that I can have an opinion, but I leave it up to my anesthesia colleagues to really execute based on the overall picture and their skill set.
There's the mutual trust clearly between the 2.
Correct.
Yeah. Victor, Alberto, any closing thoughts? What we might be able to do?
I'll let Alberto if he has any before.
Yeah.
Preference.
Yeah, no, I mean, I think the issue of very good closed loop communication is critical in our practices, right? So just having a game plan in place, and if that game plan does change, is just being communicative about that, because that's critical. The last thing we want to do as anesthesiologists is provide a service that hinders a surgical outcome for or benefit for the patient. So that's something that we always have in the back of our minds, that we're doing the right things for the right reasons for the right patient. But yeah.
For me, it's just that the basic things are basic for a reason. Just just focusing on those big picture issues and really kind of is what makes the big difference. I wouldn't focus so much on some of the minutia, like worrying about like what adjuvant you add to like a block, etc. I think that which block you're picking, what you're doing, and some of those major kind of macro things, as Alberto was mentioning earlier, looking at the big kind of entire perioperative course. And that really does require, as he was mentioning, kind of a collaboration between the surgeon and the anesthesiologist. And I'll tell you, my favorite surgeons are the ones that'll come to me and just kind of briefly discuss what we're going to be doing, you know, just because it makes it so much easier. It increases my comfort as well, because it also feels like, you know, it makes everybody, you know, for me, it makes me feel like I'm being valued. So it's really nice, because it makes me want to work that much harder to make sure that that surgeon's patients, you know, that the surgeon sees a benefit from having collaborated with us. So I'm very, that's really important to me.
Well, there's some buy-in effect, right? So if the surgeon, and clearly what Dr. Cohen does is you have welcomed your anesthesia colleagues to buy into your practice, meaning not financially, but buying into your success, because you know, you talk to them, and this is what our surgeons do here. We run our list with them, even though the schedule may say what type of block you may want. We'll still run it with them that morning, and it takes about 4 minutes. Right? It's like, oh yeah, I know this guy. He's not going to want to block. Just avoid it, even though historically you might have. So we run through it, and it takes us a few minutes, and it just adds to that collaborative care concept that we're part of the same team. And I think that's what is lacking in a lot of places. I think the four of us clearly have an intention and interest in changing that, but we still see that the culture is sometimes divided between surgeon and anesthesia. But clearly, I think we're moving the needle in the right direction.
Yeah, I agree with Alberto. Communication is the key. You know, plans change, things happen. Just have the discussion. You know, it saves for a lot of drama that doesn't have to happen.
Right. Perfect. All right. Well, we're over our time. I want to thank you guys for joining us. I hope that there's another opportunity for us to get together and talk. This was a fun conversation. That's what these are meant to be, right? Just nice, fun education conversations. But thanks again. Appreciate everyone's time, and we'll see you next time.
Yep. Take care.
Thank you, guys.